Hi everybody, this is Dr. Terri Messman Moore, and in this mini lecture I want to talk about fear, anxiety, and panic, how these things are connected and how they are distinct. So let's start with fear versus anxiety. First of all, it's really important to note that in the context of a class like abnormal psychology or when you're learning about clinical psychopathology, fear and anxiety are not the same thing. So we're going to start talking a little bit about the difference between fear and anxiety. So when we see a fire alarm go off and we see smoke and we smell smoke and we see flames, we know there's a fire. That fire alarm is warning us that we need to leave the building and seek shelter. When a fire alarm goes off and there's actually a fire, we would call this a true alarm. So when we are experiencing fear and there is an actual threat present to us, we call this a true alarm. In contrast, we might be feeling panicky about something. We may end up hitting the panic button prematurely. We may do this when we're keyed up or under stress, or various situations can come up. So maybe you can't find something, or you misremembered your schedule and you thought that you have an assignment due, but it's actually due in 2 days, but you feel panicky because you think it's overdue. So when we hit the panic button, but there's not really any threat going on, we would call this a false alarm. So one of the key differences in understanding fear versus anxiety is that fear tends to be a true alarm, whereas anxiety tends to be a false alarm. Now, one of the key things to remember is that fear and anxiety are going to feel the same way. So a lot of what we're talking about is determining whether there is a true threat. And this contextual factor is important to making those distinctions. In the end, what we want to be talking about with our clients is how we can keep calm and reduce false alarms. So coming back to the idea of the difference between fear and anxiety, if we think about fear as a true alarm, we can think about it in several ways. Fear is going to activate the fight or flight response. The fight or flight response occurs when the sympathetic nervous system, one of the branches of the autonomic nervous system, is queued up. When we're in fight or flight, we are ready to take action or to flee. So we're going to have a rush of physiological arousal. This fight or flight response is occurring in response to danger. So our alarm bells are going off. We see something, or we're thinking about something, or we feel something, and we know we're in danger. So this danger alarm is going off, and that alarm is going to activate the fight or flight response. When we're in the context of fear, there is a clear and present danger. There's an actual threat. So again, this is what we would call a true alarm. When the fight or flight response occurs, our bodies release numerous neurochemicals and hormones, and one of those is adrenaline. So you're probably aware already of what adrenaline is, but what adrenaline does is it activates the body to engage in the fight or flight response. When we're filled with adrenaline, we sometimes feel fearful, and we have significant energy. So when we're in the presence of a clear and present danger and there's actual threat going on, our bodies will release hormones and neurochemicals such as adrenaline. However, when we're in the context of fight or flight, we are going to actually use up or discharge the adrenaline. So if you think about when we're running away from something that scares us, the act of running actually uses up some of the adrenaline, right? So the body is going through an activity that is discharging that adrenaline. So after we are away from the threat, the body can begin to go back to homeostasis. So all of these things together indicate that we have a true alarm. So first of all, with a true alarm, we have a clear and present danger. It's an actual threat. That threat is activating the fight or flight response, which releases adrenaline, and those neurochemicals are discharged because we're taking action through the fight or flight response because we're trying to avoid or escape that threat or fight that threat. And all of this makes this a true alarm, and that is how we understand fear. Now, in contrast, we have anxiety. And as I mentioned before, there are similarities between anxiety and fear. Again, anxiety will involve a fight or flight response. Just like fear, the fight or flight response is going to have a very strong physiological arousal. The alarm bells are going to be going off. Danger, danger. We're going to be afraid. We're going to be scanning our environment. And again, the fight or flight response is going to kick on and give us energy to escape or to fight the danger. But the difference between anxiety and fear is that in terms of anxiety, there is no clear or present danger. There is no threat. So this is really important because the fight or flight response, in response to something that is actually not present, will impact how the adrenaline, which is released during fight or flight, how is that adrenaline going to be discharged? In this case, the neurochemicals of adrenaline and other hormones such as cortisol remain active in our body for long periods of time because there isn't an actual threat, we can't respond to it effectively, and therefore the neurochemicals are not discharged. The presence of adrenaline and other stress-related hormones like cortisol then start to create like a feedback loop which keep us anxious for longer periods of time. All of these things together, all of these facets, comprise what we would call a false alarm. Again, a false alarm is considered equivalent to anxiety, or anxiety is equivalent to a false alarm. And although the fight or flight response is happening and we're experiencing emotions and physiological arousal that's identical to the case of fear, because there's no threat, there's no clear or present danger, we call this a false alarm. So panic can be the experience of this rush of arousal. It can be the experience of the fight or flight system being turned on. So going back to this idea of a true alarm, panic can be a normal response to a dangerous or stressful situation. In fact, the vast majority of people in the United States have experienced a panic attack. It doesn't mean they have a disorder. So for example, if you're a Harry Potter fan, you may remember this scene where Ron Weasley says to Harry, "Can we panic now?" When you're in the presence of giant spiders, yes, definitely, it's time to panic. So again, we are making a distinction about whether panic is a true alarm or a false alarm based upon the context in which that panic has arisen. So when we panic in a situation without a specific cue, or our danger, danger alarm goes off for no apparent reason, this is called an uncued panic attack. And uncued panic attacks are one component of numerous anxiety disorders that we're going to talk about in this unit. Now, the name or the description or adjective of uncued is a little bit misleading because uncued panic attacks really aren't occurring at random. What's happening is people who experience these panic attacks are not always recognizing the connection between life stressors and an initial uncued panic attack. So these life stressors can be things like work-related stress, relationship loss. It could be negative things like financial stressors or illnesses. But stressors that are positive can also induce panic attacks. For example, shopping for a home or a new pregnancy. So the key here is that when individuals experience a panic attack and they feel that rush of arousal and they're looking for some cue of why they feel so anxious and afraid, if they cannot find a reason for that panic attack, they're going to be a little bit concerned. So one of the factors that's important when we talk about psychopathology in relation to panic is that individuals can actually develop a fear of panic if they don't understand where it's coming from. So what does a panic attack look like? Well, you may have already had your own experiences of panic attacks. Panic attacks are defined in a very specific way in terms of the study of psychopathology. So in the United States, in the DSM-5, we define panic attacks as the following. First of all, a panic attack is a discrete period of intense fear. So there's going to be a rush of physiological arousal. There are going to be numerous symptoms present. They're going to develop abruptly, which means they come on very quickly, and they're going to reach a peak within 10 minutes. So this is important. Panic attacks are not the same as anxiety attacks. In fact, anxiety attacks aren't a clinical term that we use in the United States related to anxiety disorders. Panic attacks are short-lived. Once you cross the 10 minutes and they don't dissipate over time, we're not probably talking about panic attacks anymore. So that's really something to keep in mind. This is a rush of arousal, it develops abruptly and quickly, and reaches a peak within 10 minutes. Now, what do these symptoms look like? I already mentioned you only need 4. Most people who have panic attacks have more than 4. So here's a whole host of different things that we can experience. On the left, you can see a lot of different types of what we call symptoms that we experience. These are subjective experiences of things like a racing or pounding heart, sweating, trembling or shaking, feeling shortness of breath. You can also feel like you're choking or have chest pain or have nausea or abdominal distress. But these first 5 components or symptoms are really kind of the classic presentation. Palpitations, heart racing, sweating, trembling, shaking, shortness of breath, and sometimes chest pain. So the chest pain is really important because, as you might imagine, if people are having panic attacks that are very intense and severe and they cannot identify a cue that's related to that anxiety, they may actually mistake a panic attack for a heart attack. So for some individuals, particularly older men, we tend to see that their presentation or the identification of panic attacks actually occurs during a visit to the emergency room when they think they're having a heart attack. Because there is overlap between physiological conditions such as heart attacks and other medical situations, we want to be very careful when we're assessing for panic that we don't assume this is a panic attack or that there's a psychological origin. Now there's these other symptoms that I'll mention just briefly: feeling dizzy, lightheaded, or faint. And there can be hot flashes or chills or numbness or tingling sensations in the body. And we can also have some cognitions or thoughts, like a fear of losing control or feeling like you're going crazy or a fear of dying. So these 2 symptoms of panic attacks are very different. They're not physiological arousal. They're more a cognitive appraisal or a label or an interpretation of what's happening. Finally, we can see 2 types of what we call dissociation during a panic attack. Dissociation can take the form of derealization or depersonalization. Briefly, derealization is when we are in a situation where we feel like the environment we're in is unreal. It might feel like you're in a dream or that you've stepped onto a movie set. People around you may seem foreign or robotic, or even things around you may look flat or two-dimensional. In contrast, depersonalization is where you feel different in your body and foreign. So for example, at very extreme levels of depersonalization, people will have out-of-body experiences. They may be watching themselves from up on the ceiling, for example. But depersonalization can also just feel very different in your body in terms of your interoceptive awareness, for example. So again, a panic attack will include 4 of these symptoms, usually more. It will have an abrupt onset and will peak within 10 minutes. So what is normal versus pathological panic attacks? So one of the ways that we can distinguish the two is that we have to remember that a panic attack is not sufficient for any diagnosis. Although panic attacks are most closely associated with panic disorder, panic attacks themselves can be normal. So when we're under a lot of stress or when we're in a dangerous situation, we may have a panic attack. So another thing to remember is that panic attacks are not seen only in panic disorder. So there's a lot of other different disorders, mostly anxiety disorders, that can be connected to the experience of panic attacks. For example, specific phobias and post-traumatic stress disorder. So if someone presents with a panic attack, number one, we can't assume it's pathological, and number two, we can't assume that they have panic disorder. We need to assess for all disorders that are connected to panic attacks. Third, what may resemble a panic attack may actually be a real fear reaction. In other words, it may be a true alarm. If you remember what I talked about before in my case related to assessment, the example with my client who presented with panic attacks and wanted me to treat her with CBT for panic disorder was in fact experiencing threats and domestic violence. In this case, it would not be appropriate to treat her for panic disorder because the panic attacks are actually indicative of a true alarm. So anxiety disorders, again, are going to be characterized by anxiety versus fear, and many anxiety disorders will involve panic attacks. This is just a brief list of numerous anxiety disorders that are found in the DSM-5. In future videos or lectures, I may be talking about some of these in greater detail. This is the end of this brief video talking about fear, anxiety, and panic attacks. I hope that you found it useful and informative as you move through the rest of your studies in abnormal psychology.